Information Technology webinars, Optimizing Communication with Information Technology, Creating the Environment Conducive to True Progress, presented by the Texas Nurses Association in conjunction with the Texas Organization of Nurse Executives. My name is Laura Ledema, and I am the C&E Program Manager for the Texas Nurses Association, and I will be the coordinator of today's webinar. Before we get started, a little housekeeping, and that is that your phone lines are currently muted, and they will be remain muted throughout the webinar. So if you have questions or comments for the presenters, please send them to us via the questions option, and we will share the questions and comments with the presenters at the end of the webinar. And please note that the webinar is being recorded for future posterity, I guess. In keeping with C&E requirements, I would like to share the following disclosures with you, and that the purpose of this education activity is to enhance the knowledge base of registered nurses in the area of promoting constructive communication between the RN and IT development team in an effort to decrease barriers and support patient safety and quality initiatives, as evidenced by development of facility-level outcome measurements that evaluate IT project success. And so the hope is that you'll be able to take the information that you gather today back and make some differences in your IT processes back at your facilities. In order to meet our purpose for today, we're going to discuss strategies for communicating the needs of clinician to IT development teams. We're going to explain common barriers to good communication between nursing and IT, and explore ways to measure and evaluate the success of a project through ongoing communication. In order to receive contact hours for this continuing nursing education activity, you've got to be doing a few things. One is you have to be registered through the Texas Nurses Association GoToWebinar system, or if you are gathered together as a group at a certain site, then sign-in sheets or a list of the names would need to be mailed to the webinar coordinator, i.e. me, within 24 hours of the completion of the webinar, and I will be sharing my email address with you at the end of our time together. Or if you're just listening by phone, again, emailing your attendance, email confirming your attendance should be sent to me within 24 hours of the completion of the webinar. In addition to that, you must be present on the webinar until its completion or actual ended time, including the question and answer time, and then complete and submit an activity evaluation form. The link to the SurveyMonkey will be provided upon the completion of the webinar, and you must complete the evaluation on the SurveyMonkey within 2 weeks of the completion of the webinar. And once that evaluation is closed, no further access will be allowed. We'll give you more information about how to do that at the end. And then upon successful completion, once successful completion has been verified, then a certificate of successful completion will be awarded for 1.0 contact hours. So, and the planning committee members and presenters of the C&E activity have disclosed no relevant professional, personal, or financial relationships related to the planning or the implementation of the C&E activity. Also included on this particular slide is the ANCC accreditation feedback line. Just in case you have some comments that you'd like to share with ANCC, then you can. That would be the number to dial in for them. All right, now that we've got all of the housekeeping stuff done, we're going to go ahead and get started. And it's my pleasure to first introduce our two presenters for today's webinars, Ms. Mary Beth Mitchell and Ms. Donna Montgomery. Mary Beth is currently Chief Nursing Information Officer for Texas Health Resources. She oversees the Texas Health Resources, the nursing adoption and utilization and optimization of their electronic health record system. She was, at one time, was an ICU registered nurse and has worked in nursing informatics at the hospital level for more than 10 years. She is a frequently sought-after presenter. In fact, she's coming to us from Wisconsin, where she's presented, and I'm sure she'll share a little bit of that with you as she talks with you today on nursing's use of EHR, as well as the professional practice of nursing informatics. And Mary Beth is also board certified in nursing informatics. We welcome back Donna Montgomery, who presented on our first webinar. Donna is currently the System Director of Nursing and Patient Care Informatics for the Baylor Healthcare System. In that role, she is responsible for providing leadership, consultation, and coordination of clinical informatics processes and integration with system-wide clinical information technology strategies. She also provides oversight across the Baylor system of the clinical informatics teams that implement the electronic information systems that support patient care delivery at the Baylor system. Donna is also board certified in nursing informatics and has held many nursing leadership roles in oncology administration, patient safety, quality, and informatics. So with that in mind, and without further ado, I'll now turn the webinar over to Mary Beth and Donna.
Hey. I want to welcome you all, and while we're getting switched over, this is Mary Beth, and I'll be driving the presentation today. So can everybody see it? Laura, can you verify that we're up and running now?
Yes, I can see it on my screen, yes.
Okay, so oops, I'm getting ahead of myself. So I want to give you a little bit of background just for a couple of minutes on our TNA Tone Health HIT Committee. And so these webinars are being presented to you from the TNA Tone Task Force, and we are really working to spread nursing informatics throughout the state of Texas, and we're doing that in a variety of ways. We're doing that through informatics practice and through education, and we're also being associated with the Tiger Initiative on a national level. And these are some of the things that we're doing. We're looking at benchmarking ourselves against other reports on progress of how we're doing against other initiatives. We're looking at healthcare reform, things related to meaningful use, the advanced practice nurse roles, EHR incentives, the IOM and Robert Wood Johnson Foundation report on advancing healthcare, and the informatics nurse standards by the ANA. Those are the things that guide us. And as I mentioned, we're really looking at helping disseminate information about informatics and health IT, and we're doing that through CNEs, such as this one, through our awareness campaign, through nursing curriculum development and health IT, and through our participation with the Tiger Initiative. And I won't go through all of these, but this is a list of our HIT committee members. They represent both the TNA and Tone membership, and represent nursing practice, informatics, and academia. And these are our statewide priorities. You can see that, as I've already mentioned. I want to go through these pretty quickly. I think Laura already gave you our objectives, so let's just go ahead and get into the content. And with this, I'm going to turn it over to Donna for the first part of this presentation.
Thanks, Mary Beth. Welcome everyone to the webinar today. What I'd like to talk with you about today are primarily around Objective 1 and 3, and Mary Beth and I are sharing the objectives, but I want to give you some examples of things that in my practice here within the Baylor Healthcare System, how we are looking for opportunities to enhance our communications between our clinicians at the bedside taking care of patients, and how the electronic tools are developed, making sure that we're getting it right for our end user community. So one of the things that I will tell you is that we have learned that we had some clinician dissatisfaction with our EHR. We all know, I think, on this call already that this is probably a national trend in particular areas within our EHR. Sometimes that's a functionality limitation. Sometimes that's how we built and designed something, as well as other reasons. Some of the evaluations that we've done within my organization is trying to understand where that dissatisfaction with the EHR is coming from. I've given you some references at the end of today because I didn't want to put all the references on the slide. They end up taking quite a bit of space up, as you all know. So I've given you some readings at the end that if you're interested in this work, you might be able to reference. A group of nurses from within our organization really did a simple heuristic evaluation and began to find what we call heuristic violations that have occurred that they found in our EHR, and that was actually just in two main areas. So we knew that the way that we were talking to our IT partners about what we needed built in the EHR to support clinical practice, really we had some failures in that communication. We continue to see large amounts of change requests coming from the end user community, another signal to us that we're not getting it right in the build and how IT is understanding what it is that the clinicians are asking for. Next slide. So another measurement that we did is we measured through surveying our clinicians, primarily pharmacy and nursing were the two groups that we surveyed to find out overall what is their experience with the EHR and what were the results. And we've used these results to categorize the type of work that we need to use, that we need to implement. So you can see that we had we believe we had policy and design work, we had some infrastructure work, some things about a workstation deployment and application of our systems, and as well as the hardware. So we did take this and break it up. You'll see some of the things that we did to help try to get our communications more clear with our IT partners, and making sure that we were really translating the voice of the clinicians back to them. Next slide. So some of the findings that we had in our survey, as I said, we categorized into different categories. We have an HIT, Health Information Technology subcommittee of our Patient Safety Committee. That's a place where we're really able to talk through, what parts we got right and what parts we didn't get right. And that's been a very helpful way for us to come together with our IT partners, our patient safety leaders, our quality leaders, as well as our informatics leaders, to really figure out some of the next steps that we need to take as an organization, whether that's in a specific part of our EHR. Like one of the areas we're working on right now is in our falls and risk assessment of our patients and how we document that. So that's something we're working on right now. But really, we've used this team to help us solve many problems and to try to get agreement across our health system about how we're going to attack things and then get it built in the EHR, which most of you know that many of the things that are difficult around implementation have to do with how do we get standardization across all of our hospitals, because they're all using the same tool to document and care for, and to help support the practice of the clinicians. So some references here, some of the different work that some of our informatics leaders across the country have published for us to learn from. Some of the things that we've pulled out that we're doing within my organization is that nursing and patient care, we've identified informatician roles specifically to help focus on this work, and that those people are seen as the individuals that help bring forward the recommendations and really translate the needs of the clinicians, how that should look in the EHR and what those changes should be to best support practice. And some of the informatics, tactics also that we're using is ethnography and direct observation. I'll get into that a little bit more. I'll give you some examples of that. Task analysis, which is really understanding the workflow and what nurses and other clinicians need to do to use the technology that we've given them, and then collecting data and trying to see if what we thought we were going to improve, we really have. Next slide. So this is an example of some of the observation, one of the observation tactics that we've used to really begin to understand how our clinicians are using the application. One of the complaints that we've heard, and some of you may have this same complaint, some of you may not, is that the documentation in the EHR is taking nurses, in particular in this observation set, was taking our nurses longer than when they did documentation in the paper world. those of us that do this work every day know that there's lots of contributing factors to that, and that in fact we may be taking longer. Is that because we're requiring them to document more information than they did in the past, or giving them a structured way to document that sometimes takes our nurses longer? But really what we were trying to accomplish was, let's dive into this and figure out what is taking them longer so that it'll help us when we're figuring out where we can streamline things. We wanted some real data and some evidence to help us with that. So you'll see in this example that we begin to observe that one way the nurses can document in our system is they can use something called the shift assessment, which is more of a structured note, or we've also given them the option of using a flow sheet. You can see from these results as an example that we see that when they use the structured note, the time that it takes them to complete a shift assessment was significantly less than when they use the flow sheet. So we've used this information to help us from a policy and procedure perspective, and as we eliminate things, because what we found is that we gave the nurses too many options. So we're going back and beginning to eliminate some of those areas so there's not so many options, and we'll be remeasuring this as we make the changes in the EHR and see if we really accomplished what we thought we were. Next slide. So we did some similar observations around medication administration as we are implementing our barcode medication administration module within our clinical system. We wanted to know, is it going to take our nurses longer to administer meds or not? And I think the literature does really support our findings, which is that even though the nurses feel like the barcode medication administration really supports them and gives them a safety net, and they don't want to go back once they start using it, when we just look at the administration and delivery of medication, administration and documentation of those meds, it does appear in our data that it's taking longer. What we did dig into are what are some of the other issues that are contributing to how long it's taking. So you see some of our infrastructure issues that we've pulled out here and that we're working on. The barcode medication administration did not reduce our overall time for review and documentation in the EHR, but our nurses are pretty satisfied with that technology because they feel like it really provides a safety net. Next slide. So one of the things that we've done within our organization is what we've learned is that if we only rely on change requests that come from our end user community, we really end up finding that we'll make a change in our system based on what our end users have told us, but then what happens is you may create another issue. And so then you get another change request that almost negates the first change request. And, you know, it can become a cyclical problem where, you know, you're not looking at solving the problem in a broader perspective. So that's really where we focused a lot of our time, has been how do we get the design right from the beginning so that we're not you know, working on the same things over and over, or we think we fixed something and then we start hearing about a new problem that we've created. So this is a framework that we're testing within my organization about how we get ready to engage with IT and how we hand off build requirements to them so that we can really be very clear in what it is that we need for them to build. Now, we don't tell them necessarily the exact design or how to build it. We give them ideas. We collect these inputs so that we make sure that we're not missing or creating a large hole where they're going to have to ask a lot of questions and say, well, we really can't design this because you haven't really told us X. which is what we were finding before we started using this method. So you can see along the top that there's a lot of things that we have to know before we start designing a new solution or a revised solution in the EHR. And it does take, different experts within the health system to help us gather these inputs and make sure that we have, that we really understand them and how it may impact the problem that we're trying to solve in the EHR. Sometimes we're looking at all of these, and other times we may be looking at a subset. So Falls is probably a really good example of a much larger project that has really affects more things in the EHR, and so many of these inputs, almost all of these inputs, had to be addressed for us to optimize our fall documentation, where if we're looking more specifically at a smaller change, like the way nurses document lines, tubes, and drains is another project that we did. We had a subset of things that we looked at within our inputs. Next slide. So once those inputs have been gathered, really, this is just a little bit of a process map to kind of show you the way that how we take multiple steps to get really to the end solution that our clinicians are asking for. And so once we've gathered the inputs and we really understand the problem we're trying to solve within our clinical system, one of the things that has to happen, and you'll see this in box 2, is that we need to really write some solid build requirements so that our IT partners can really take that from us. Many times we include things like we'll mock up a screen. We might take a screenshot of our current state and begin to say, well, if we're going to use, a specific risk assessment tool like a Johns Hopkins tool, these are the things that would need to be different in the future state. And so we might, draw something, or we might have a screenshot with, lines drawn through it to give them some ideas about how we're trying to translate to them the needs that our clinicians have articulated to us. So there is a lot of work in not only gathering the inputs, which is really done in our first step of the process, but to be able to really hand off a complete set of build requirements, which is our step 2 in our framework here, takes a tremendous amount of time, and really needing to document, how the current state in our system might change with all the inputs that we have, and really trying to solve the problem. So once we do that handoff to our IT partners, then we begin to engage with them in really rapid design sessions where we begin to get prototypes back from them, and them saying, okay, this is what we think you told us. Let's sit down and dive in and see if we got it right. And it allows us then to really, in those rapid design sessions, to really go back and forth, reviewing, using our requirement document as our foundation, but really going back and forth and saying, giving them feedback, and then them telling us whether the functionality will allow it, or what we might be able to do, or another way to think about something that they may see the technology can really support what we're asking them to deliver to us. We come up with really good conversations and discussions, but what I've learned in my practice is that if you don't start with a documented set of requirements, it's really difficult for our IT partners to understand what we're trying to tell them, and we end up getting in a lot of circular conversations, and they get very frustrated with us, and rightly so. Because they need things in writing. They need to understand exactly what the scope of the project is, so that we don't keep getting scope creep and changing it on them, what it is that we're asking them to do for us. So once we have that prototype, and the work group is working together with them on how that build needs to look, you can see in step 6 we get into more of a complete build. And what we do here, you all probably do some similar things, but we have a phase that we call clinical charting. Clinical testing, I'm sorry. Here we call it shadow charting, which really is just a similar term, except it encompasses a review of current policy, make sure nothing's changed since we have a new build, and looking at the workflows, getting feedback from the end user community to make sure that we got it right and that our clinicians are understanding the changes and giving us feedback that, yeah, we got it right and this looks good. Documenting any of the issues or problems in that process, and then looking, most of the time those changes are pretty minor that might need to happen, so we kind of call those tweaks. We sit back down with our IT partners and discuss those, figure out what they can do and what they cannot do. If for some reason we really find a huge gap, which would be more on the right side of the model, then we have to end up going back to our build requirement and our spec document and figure out what we missed. Since we've been using this methodology, our changes have been minor. So more to come on that as we continue to test this. We may need to revise the framework, but this has really helped us be much more clear with our IT partners and help level set, keeping our scope within a specific boundary, and allowing us to move more quickly than we've been able to in the past. Next slide.
Okay.
So Mary Beth, I'm going to turn it back over to you so that we can talk about some different barriers to communication.
Okay, thank you, Donna. And as Donna suggested, she's provided a framework of how we manage communication, and I'm going to talk about the landscape a little bit and some of the practical applications and things we're doing within our organization to facilitate communication, and then also just some of the differences between the nursing point of view and the IT point of view and how we can work around those variances. So really, there are several barriers to communication in the hospital, and a lot of these you're aware of. We're dealing with sensitive information, and so everything that we do in communicating has to be framed around the privacy and security of information. So when we look at communicating to our other departments, the security and privacy aspects are paramount, and they're also built into our systems so that sometimes those may actually seem to create a barrier in how we're able to communicate to other departments. We're also working a shared environment, so we aren't able to use the same type of communication devices in the same ways that other industries might use. So for example, our nurses don't really carry their smartphones. We don't use personal devices to communicate in the hospital, and we have to look for how to manage communication across departments when we're not necessarily using standard telephones or smartphones. And then we also have increased noise levels and the need for patient privacy as we talk within departments creates a barrier. And then we've got people coming and going all of the time. So all of those things affect our ability to communicate with each other. And this isn't just within nursing and IT, it's really just communication between departments as well. And our basic landscape is that we have the access to information. We can access information anytime, anywhere. In the hospital, you can access information externally, and externally you can access hospital information in some cases. We're also seeing an increased use of smart devices, smartphones and tablets. And then finally, we have a better informed public. And so the way we communicate with our patients and families, I believe they're expecting more and more from us. And we're also seeing the advent of things like patient portals and internet access to different types of information that facilitate communication. So who is it we really need to communicate with? We need to communicate between caregivers, we need to communicate to our patients, and we need to communicate to families and others. And really IT is within that caregiver world that really is people within the hospital environment. So where I think we're headed, and those are the two cutest grandchildren ever there, and they are 2 years old playing with their smartphones, and they are 5 now, and they have their own iPads. So, and I think that's pretty common. I'm sure all of you can relate to that, or with your children. But where we're really headed is with more and more mobile device use. And so we're seeing more and more tablets and smartphones. And these devices are being used for communication in a greater way, not just for talking on a phone, but messaging through the use of portals, through apps that we have, and also through our patients. And we have the ability now to communicate to patients and through other departments through the use of these devices. We can also provide education. So there's an increased focus on privacy and security as well through these devices. We also have a lot of non-traditional communication that we're seeing through wireless devices. I'm going to talk a little bit more about some of that, through secure messaging. And I'm careful not to use the word texting, because texting obviously is not secure, it's not private, anyone can pick it up and it's not allowed. But secure messaging is a way to send encrypted messages to targeted caregivers about patients or information, and be able to track that, have an audit trail, and make sure that it's going to the person it's intended to. And then we also can communicate through social media sites. So some of our communication strategies that we have used internally between staff to staff, and this is within our clinicians, but it's also within IT, and so from our clinical departments to IT. So we're looking at greater use of tablets and smartphones, and within nursing, we're really starting to look at the use of smartphones as a tool to facilitate communication between departments and between patients. Also, secure messaging. We're starting to look at sending messages to our patients, receiving messages from our patients, and messaging between caregivers. I foresee sometime, and I hate this being recorded because now I'm going to be quoted as saying this, but I foresee sometime in the not too far future that we will actually be doing secure messaging of orders between physicians and nurses instead of telephone messages like we do now. And then again, social media. This is a screenshot I've captured down here of our internal social media site and how we can communicate between the different departments within the caregivers. And it's called Yammer, and we use it similar to Facebook, except it's inside our firewalls, and it has all the privacy and encryption attached to it. So we communicate a lot of different information within social media. Another thing that we use is Vocera. Some of you may have seen these. These are the communication devices that you wear that are wireless, and you can call up any caregiver within your network. And where we're headed is with smartphones and with the secure messaging. And there's many different companies that do this, and you can have the apps on an iPhone or a shared device. We also communicate with our patients and families, and I think I've got some pictures here. One of the things we do to facilitate communication within our NICU is our parents can call in and see their babies, and now we have voice communication so they can actually talk to their babies in the NICU, and the nurses will put up notes to the parents from the babies, and it's really help those parents adjust to a difficult situation. We also have one hospital where we're giving tablets to patients at discharge so that to cut down on readmission so they can communicate back to the nurse, and we can also monitor their compliance with follow-up items. And then we have a patient portal that patients can access their healthcare information relative to their visit. We're also looking at making that portal active for inpatients to keep them up to date with what's going on during their hospitalization with things such as their lab work, their scheduled procedures, when meds are due, and they can actually communicate back to their caregiver and ask questions. They can make requests for water, for assistance and other things. And then we're also integrating our patient education through the patient portal and having more two-way communication between the caregiver and the patient in terms of their patient education needs. And let's see, here's an example of our patient education and the access through the portal. So some of our challenges around communication, and as we start looking at these highly sophisticated communication devices, there's still a perception that the staff are playing, that they are not working if they're being seen using a smartphone or sending a message. We assume they're texting a friend, not trying to communicate lab value to a physician, for example. And also, we have trouble keeping up with greater expectations and knowledge from patients and families. It's getting harder and harder to not only keep up with the medical and nursing knowledge, but to also keep up with the expectations and the technology. And then, as I've alluded to, the existing paradigms around texting and messaging. Texting brings out, such a negative connotation, but yet messaging and secure messaging is really going to be a primary tool for communication in the future. And then trying to maintain privacy and security of our patients and the information that we're communicating has to be at the forefront of any conversation about communication. And then finally, it's expensive. We can't just go out and buy an iPhone for every nurse in our hospitals to have to use as a tool. So we have to figure out how we're going to manage the cost and the resources to build these. The opportunities around it are really great, though. We have an enhanced ability to meet our families and our patients' needs, and we have better outcomes, potentially, increased patient compliance, and more patient engagement. And as you know, with Meaningful Use Stage 2, that's really where we're headed, is patient engagement. And these communication tools help us become more engaged with our patients. And then we have faster and more relevant communication. So let's talk specifically about IT to nursing. And Donna talked a lot about strategies for communicating the nursing needs to IT. But I think it's equally important that we understand that IT also struggles with how they communicate their needs to nursing. And so what is it in nursing that we really need to know about IT? And just a couple of things I think that drives the IT mindset that we don't quite get as nursing. About 80% of the IT resources in most organizations are committed to maintaining current functionality. So it becomes difficult to add additional projects and do all the cool things that we want to do when most of the IT resources are committed to just keeping the lights on and keeping the systems that we have going at their current state. The other thing that I've really become convinced over the last couple of years is IT works in a different way. So they work off of project plans, task lists, allocation of resources. Their work is driven by tickets or by these project plans. And clinicians, we work from triaging, prioritizing, we multitask, we manage many things simultaneously, and we work from a nursing process perspective. So I think it's difficult for those two different fundamental ways of managing our work to really have effective communication. And I'll give you a quick example that I just had this morning. I was talking to an IT person about developing service level agreements for user provisioning. So when a new nurse comes into our organization, how long does it take them to get all of the access that they need? And we're having issues with that, because we need them to have access to the EHR within about 5 working days of starting. And she was telling me that their service level agreements needed to be based on how long it took the processes to work to get them the access, which today takes about 10 to 14 days. And she wanted to base the service level agreements on that. And I was like, well, that's crazy. Why would you base service level agreements on an expectation that's already beyond what our needs are? We can't wait 10 to 14 days. We need access in 5 days. Your service level agreement needs to be based on 5 days. And she was saying, but we can't do it in 5 days. So this is the kind of communication struggles that we have between nursing and IT, and how do we meet the needs of both of these departments. Also, IT works on one project at a time, and they count their hours that they spend against the projected hours for that project. So they're really tracking their hours. we don't necessarily complete a task before we move to the next task. So we're constantly getting interrupted, and we thrive in that environment of constant interruptions, actually, I think. But for the IT folks, they don't know how to manage in that environment. They need to be able to manage their time, manage their project plans, and move towards those outcomes. So IT is also heavily focused on governance, and Donna was also talking about governance in her methodology of how they manage these requests. And we have to really be able to work within the IT governance, because that's where the allocation of the resources and the management of those resources comes. And then Donna also talked about the granularity that IT needs. So we may request something, but we don't get it down to the level of detail that they need in order to execute a plan. And so what I'm convinced about is we all want to do the right things for our patients. And IT also, they feel that they are in the business of supporting patient care, and what they do is really to support us in what we do. And they're very proud of that, and they have a lot of responsibility in meeting the needs of our clinicians and our patients. So how can we, as nursing, support IT communication? I think we really need to understand their approach, that they care about the outcomes as much as nursing, but they do have a different perspective. And they don't always understand how things may impact the patient care experience, but they want to. And as more and more clinicians are entering IT, I think that's changing. And as our IT analysts and programmers and everyone spend more time in healthcare, they certainly get a lot of experience about how healthcare works and what our needs are. We need to make sure we can explain things in detail, that we organize our thoughts, and that we plan what's needed for them. We need to give them the detail. We can't just say, I need a report on, the admission history. We need to tell them exactly what level of detail they need. And then we need to work jointly with them to make sure that we're communicating the same thing in the same way. We also need to realize that they're supporting many projects, and they may not know what our priorities are. So they're prioritizing based on resources, allocation of resources, cost, and they don't necessarily know what our priorities are unless we tell them. And again, they're very proud to be part of healthcare, and they feel that supporting nurses and clinicians is their gift to us, and that they really want to support us in that. So some of the things that we've done, in addition to really just working on the communication and understanding them and striving to get enough detail to them to adequately plan their projects, is shadowing, having them shadow with us, and having the IT people in our organization, they come and spend 1 day a year in a clinical environment following a clinician around, so that they can get a perspective of the workflow. And we do that every year. Well, we actually do it twice a year. We do 4 hours twice a year. So it's kind of that walk a mile in their shoes kind of perspective. And I hear that they really love that, and they really see how multidimensional the clinical environment is. So I want to talk a little bit, too, because of the work this HIT task force is doing, just about communication between organizations and communication in our community. And I think networking is so important. And as Donna and I have discovered this year, we all need each other so much, and we need to reach out to our peers between our organizations and within our community. So benchmarking with other professionals in nursing informatics and just other clinicians within other healthcare systems. So in the Dallas-Fort Worth area, we have our DFW, Nursing Informatics Group. We meet quarterly. I guess this is a shameless plug. We meet quarterly for an education networking event. We also have our LinkedIn site where we can communicate more informally. On the national level, there's organizations where you can join your professional organization. I belong to HIMSS and ANIA, which allow us to communicate between informatics. And then getting involved in nursing informatics in your other clinical organizations. And it's really important to share our successes and also to share our lessons learned. And we do a lot of communicating. You should be publishing, you should be presenting, and also developing research studies, things that we can do to show our outcomes and show the things that we're doing that we can share with each other. And then communication in the community. I think Donna and I probably had a similar slide. I think that last slide was Donna's. I'm sorry, Donna.
That's okay.
Okay. But anyway, I think I had pretty much the same thing. We need to network. We need to make sure we know what's going on in our community, share our best practices. And again, here's some information on our Dallas-Fort Worth Nursing Informatics community, and we do have an e-list. You can contact me or Donna Montgomery for more information about the events that we have planned in the DFW area. And also with the TNA Tone HIT Task Force, we're working on making that available at a state level and creating a statewide informatics communication networking group. Donna, do you want to address your references?
I just included them in case people were interested in any of the articles that I used as part of how we did our structure and how our framework development.
So with that, Mary Tietze and Nancy Kreider are our chairs of the HIT Task Force, so their contact information is here as well if you want more information about the work of the task force. Donna and I gave you our contact information, and I think with that we'll open it up for questions.
Thank you, Mary Beth and Donna, for the excellent information and insights you have shared with us today. We do have some questions, and I'll go ahead and share those as soon as I can see them. There we are. The first question is from Mary Tietze. We are interested in more use of patient portals and wondered if one of the presenters, I just have a question, that's right. Oh, if one of the presenters could speak to the integration of the patient's information among different patient sources, such as their physician, clinic, hospital, et cetera, outside of a given healthcare system. So again, let me reread that since I got caught up a little bit. Yeah. We are interested in more use of patient portals and wondered if one of the presenters could speak to the integration of the patient's information among different patient sources, such as physician, clinic, hospital, et cetera, outside of a given health system.
Yeah, this is Mary Beth, and I'll start with that. I think, Mary, you've hit on a really good issue that I think we're just starting to really explore, because there are a lot of patient portals out there, and different physicians and hospitals have portals. I know personally I have 3 portals now, and we really do need to get those portals integrated. And the other thing within our hospital-based portals, we're not really pulling in a lot of the patient developed information. So right now we have a lot of portals, and we're just starting on this technology, but we don't have a lot of integration of those portals. And I think over the next 2 years we're going to see the integration of the patient information along with the healthcare experience, along with the ambulatory experience. But what I'm seeing right now is we're not there yet. And we have more national initiatives like the Blue Button Initiative that originated, I believe, with the VA, where we're really encouraging patients to get into portals. They can sign up for portals on their own, but then we still have to figure out how we're going to integrate that healthcare information into the whole healthcare continuum. One thing that does help with that a little bit, and I think we'll see more of this integration, is around HIEs and how we manage our health information exchanges, because that is a possibility of integrating data from multiple sources.
So I'll just add to that, Mary Beth. I agree with everything you said. I think the other thing that we are learning is that, and meaningful use is really pushing us to begin to test and send information and exchange it with people outside of our own health systems. So in stage 1 we had to do some testing, but we really didn't have to be successful in sending that. But in stage 2, some of the standards are pushing us even further. I think that a lot of organizations are counting on their HIE, which will allow us to see like a summary care document that will give us basic information like demographic information, medications that patients were on, allergy information, etc., will allow us to see that and share that between health systems or between providers, etc. One of the things, though, that I think we're beginning to understand is that that summary document really is not going to give us all the things that we need to know about a patient, and being able to configure our systems to actually do true interoperability where we can pass data elements to each other. There's some great work that Kaiser and the VA have done on this, and we're all, I know within informatics, we're really trying to learn from them about how they did this. They did their work around pressure ulcers, and so that might be something for us to explore a little bit more in the future at another time. But thanks for the question, Mary. I think it's very appropriate.
And Mary says, thanks back to you all, that helps and may be an area for more research. So the next question is in regard to the workflow slide provided by Donna, where the articulation of nursing's need to IT is accomplished. Has there been a measurable improvement in staff satisfaction and or patient care delivery outcomes?
We are actually, great question, thank you. We are administering that survey. I'm actually trying to find out the exact date. Our patient safety department administers that survey for us and helps us put that information together. So we've had many implementations since we did the initial collection, and we're getting ready to resurvey. So I'd be happy to share, if you'll send me your contact information, our findings to be able to answer that question. I'm just as curious about it as you are, so more to come on that.
So, and that was Mary T. asking that question also, with an awesome thanks response. So at this time we have no further questions, and I know that young Mary Beth needs to go catch a plane. So I would like to, at this point, thank both Mary Beth and Donna again. And although they won't be able to hear you, let's give them a round of applause for the excellent information that they have shared. Before you all sign off, please note that the information, we're going to go to the next slide, related to applying for contact hours, okay, and just some additional information. As I mentioned at the beginning, you need to complete the activity evaluation at the following SurveyMonkey link, okay. The link will be provided to you via an email from Erica Bruner, who is my lovely administrative assistant. You will get an automatic email survey or evaluation from the webinar company, but what you are looking for is the email from Erica Bruner, and it will have the SurveyMonkey link to it. If you are sitting in a group or you are on the phone, you'll need to get that information. Share it with people that might be around you so that everybody can have access to the link. Access to the evaluation link will close in 2 weeks, which will be around May 10th, and certificates will be issued via email the week of May 13th. And if you have any questions, my email address at elderma@texasnurses.org is on the slides, and you can always contact me via the Texas Nurses Association. So on behalf of the Texas Nurses Association and the Texas Organization of Nurse Educators, I want to thank you very much for your attendance at today's webinar, and I want to thank you for what you do for nurses and for patients and for patients. Thank you, and have an excellent afternoon.